Thanks for coming today to another of our speaker series. This one includes, because of the speaker, is also part of our speaker series for the T32 training program in addition to the CCS speaker series. We are delighted to have one of Miami's academic superstars here, Willie Prado, from the University of Miami. Willie is exceptionally well known for promoting behavioral and mental health in Hispanic youth. I knew about his work for substance use work, just fantastic work on interventions and prevention of substance use in Hispanic families, and I'm sure we'll be talking about that as part of what he does. Surprisingly, he only got his degree 15 years ago, is that right?
I think so.
2005 from has 150 publications, more than 300 presentations and papers. Nationally has been funded on grants since since he graduated from NIH, mostly NIDA. Mostly NIDA. He won the Early Career Award from Society for Prevention Research almost right away after he started his career, and he now is the current president of the Society for Prevention Research on lots of different review boards for journals, Associate Editor of Prevention Science, is that right?
Past, yeah. In a past life.
In past, okay. And is on lots of NIH review panels. So a good person, if you have a chance to hang around for lunch, you'd be a good person to shake his hand and show your face to his, so that if he's reviewing your grant in the future, he knows who he's talking about. So very happy to have Willie here. He's also a member of the National Academies of Sciences, Engineering, and Medicine's Committee on Prevention and Control of Sexually Transmitted Diseases. In the U.S., it's hard to get to be on the National Academy of Science. It's very impressive. And did I say he was currently the president of SPR? Yes? Okay. So we're really happy to have Willie here. Thanks for coming to the talk, and please help me welcome him. I forgot to tell you, he's the dean of the graduate school at UM and a professor of public health.
Thank you. Thank you, Bill. Appreciate it. Thank you. Good morning, everybody.
Good morning.
See, folks avoid the front, but that's okay because I walk around, so I will make sure to reach all of you. So thank you so much to Dr. Pelham and to his team for the invitation to be here. It's really a pleasure, and FIU feels like a second home in a lot of ways because I was actually a faculty at FIU a number of years ago, and still have a lot of colleagues. Actually came early this morning to meet with some of those colleagues. So it's really great to be here. So I'm here to speak to you predominantly about one intervention program that my team and I have been working over the past 15 years with. And this is Familias Unidas, or United Families, and it's a behavioral intervention, as I'll speak about very soon, that we've been evaluating it over the years, mostly in the prevention of substance abuse and sexual risk behaviors, although all over the years that has also translated and the intervention has been adapted to also target mental health, target obesity prevention as well. I'll speak a little less about those studies, but I'm certainly happy to expand on that either during the presentation, during the Q&A session, or if I have an opportunity to meet with some of you after the talk, to do that at that point in time as well. So essentially, what is Familias Unidas? Familias Unidas, as I mentioned, it's an intervention that my colleagues and I developed around 15 years ago or so now. Developed through, in large part, collaboration with an advisory board consisting of parents, of adolescents. We mainly have been delivering the intervention in the school system, so that advisory board consisted of individuals from the school system, teachers, principals, etc. And the intervention over the years, we've evaluated a number of different clinical trials, mostly funded by NIH and CDC, where we found that the intervention has had some strong effects. And I'll very briefly go over some of those findings. The intervention is parent or family-centered, where we place the parent in the leadership role of the family and change behavior of the adolescents by changing behaviors in the parents, mostly behaviors around parenting. The intervention is delivered in 12 sessions over 12 weeks, and I'll get into a little detail about the sessions, but 8 of those sessions are parent-centered, where parents get together in a multi-group format. And there's a facilitator where through very much a participatory process, not being didactic, we really solicit a lot of the information from the parents themselves. And then there are 4 sessions where the parents then have an opportunity to practice some of the skills that they learned, skills around behavior management, skills around effective communication, around parental monitoring of peers, where they then practice some of those skills that they learn in the group with their own adolescents, sort of one-on-one, with the presence of the facilitator or coach to really facilitate some of those conversations. So our work, and I won't go through this, I know I'm preaching to the choir here, is built on Bromford-Berner's work on the social ecology, where we believe that adolescent behavior, its influence from things that are most proximal to the adolescents, a lot of microsystemic factors that you all are very familiar with, things like parent-adolescent communication, parent-adolescent communication, to things that are much more macro. So for example, in the exosystem, one of the things that we strongly believe is that parental social support can really play a huge role to change and support parents, and in turn, that will impact some of the microsystemic processes. So how do we accomplish the goals of the intervention? These are it. Essentially, we instill hope in the parents. We have typically, over the years, worked with a lot of Hispanic immigrants. Approximately 50 to 60% of our samples over the years are all Hispanic, first generation or second generation. And the parents feel disempowered. They feel that they've arrived to their country, and with all the changes and everything happening with acculturation, and not only acculturation of the parent, but also sort of the differential acculturation between the parents and the youth, creates that the parents feel that they have no hope. So we try to really instill that hope in the parents. As I mentioned earlier, the intervention is family or parent-centered, so we place that parent in that change agent role for the family. As I mentioned, we strengthen parental investment, and we collaborate with the different worlds that the adolescent is embedded in. So our focus is on the family world, but we also do quite a bit of work within the school world and within the peer world. So for example, one of the sessions that we do is that we invite the school counselors to participate in the intervention so that the parents have an opportunity to interact with their kid's school counselor, which oftentimes does not happen, at least with this population. As I mentioned, some of the other ones, we create social support networks for our parents. We do this with our face-to-face intervention. Over the years, we've developed an online adaptation of the intervention, and that has become much more challenging, obviously, as you can imagine, to really create these social support networks when really the parent is watching these sessions online at the comfort of his or her home. We provide skills for parents to really talk to their kids around sensitive subjects, specifically around substance use and particularly sexual risk behaviors. With Hispanic families, is a conversation that we typically tend not to have with our children. And so we really create an environment where by the end of the intervention session, even those parents that came in and they said, we're going to enroll after some incredible engagement work by our facilitators, and these parents finally decide to enroll, they're always very hesitant about sort of some of these goals around speaking to your child around drug use and around risky sexual behaviors. And one of the things that we always tell the parent is, you are in control of your family, and you are in control, and you should feel free to talk to your adolescent about what you would like him or her to sort of practice, whether that be condom use or whether that would be delay of sexual initiation. But oftentimes what we see is that by the end of the intervention, the parents are really having these conversations with their adolescent. Finally, one of the things that we do in these 4 sessions where the parents have an opportunity to practice some of these skills that they learn in the group is that we really do try to restructure maladaptive family interactions. Although we, for the most part, we deal with a primary prevention sample, so these are youth who really have no risk, and we really are trying to prevent some of these behaviors, in that we have also worked with populations that are much higher risk, much more indicated. So we have done a study in collaboration with the criminal justice, where these were adolescents who had created some type of criminal offense, and we're going through their diversion program. So those kids who were at significant risk, 50% of them were using drugs, a lot of them were engaging in risky sexual behaviors, and thus, at least in that particular sample, there were quite a number of maladaptive interactions that stem mainly from within the family. And so we really use that opportunity to work on the family dynamics and on the structuring. Over the years, we've done work from some, as I mentioned, intervention development work, feasibility and acceptability studies, and have sort of worked our way up this continuum. We've done a number of efficacy trials. After that, we have sort of moved on to effectiveness, to larger trials, real-world trials, where we have trained facilitators outside of the research team to deliver the intervention. So in our most recently completed effectiveness trial, we worked in almost half the middle schools here in Miami-Dade, and we trained the school counselors and the school social workers to deliver the intervention. And so the research team, at least in this effectiveness trial, was a little further removed from the actual implementation of the intervention. We're currently now somewhere up here, and currently doing and are planning some dissemination implementation studies, and I'll end a little bit with that to give you a sense of some of what we're doing now and some of what's currently being planned, actually under NIH review at this point. So very briefly, I'm not going to go through all the findings here. So this is one of the papers that we published on this particular study that I just mentioned within the criminal justice system. I'm going to jump in to the design and some of the results of our effectiveness study. So as I mentioned, we worked with approximately half the middle schools here. We recruited and randomized 746 Hispanic youth and their families into one of two intervention arms. The first intervention arm was the intervention, and the second intervention arm was standard of care. So this mainly consisted of the typical sex education classes that are offered to 8th graders here in the Miami-Dade County Public School area. So we followed this particular sample, as probably is consistent with most of our studies, not all, for 2.5 years post-baseline. So to give you a sense, they were recruited, they went through the intervention for those in the experimental arm. Then after that, they were assessed about 3 months after the intervention, and then 9 months post-intervention, or 6 months post-baseline, then 18 months, and then 30 months. And we typically tend to do pretty well in our retention rates. We never really sort of fall below that 80% threshold for 2.5, 3 years, 3 years post. Won't go through this. You can read this at your leisure here. But again, sort of consistent with what I said, a significant proportion of our adolescent population are recent immigrants. The demographics over time has changed. When we started these studies 14, 15 years ago, it was fairly common to have 60-70% of the sample be of Cuban origin. And that is really not the case anymore. Actually, Cubans represent the minority of our sample. And what we are seeing is we're seeing a lot more Venezuelans and Colombians, which is probably consistent with perhaps some of the changes in the demographics that you've seen here, both in your studies and your practice. We work with fairly low SES families. So these are parents whose income is on average less than $40,000 for a family of 4. And by the way, please feel free to interrupt me. Sometimes I speak a little quickly, so I'm happy if you just raise your hand. I'm happy to slow down. So for this particular effectiveness study, as I mentioned, one of the things that we did is that we really trained the school workforce to deliver the intervention. Over the years, we had a research team of wonderful clinicians, social workers, psychologists. We're really pretty quite stellar in delivering the intervention. But now we wanted to sort of take this, and this was sort of, I would say, sort of our real first attempt at training others to deliver the intervention. Before this particular study, everything was had been done in-house, where it was really the same 3 or 4 individuals delivering the intervention. To date, now since this study finished, I guess probably about 7 years ago now, we've trained about 350 clinicians all across the country and even abroad to deliver the intervention. I'll very briefly speak about that later on. But what does our training consist of? Our training consists of 4 days of training that one of our master level clinicians train in a number of different approaches, how to engage families into the intervention. There's sort of the process part of the intervention and then the content part. And so we really sort of train these individuals in both aspects of that. and how to reach high fidelity to the intervention. Over the years, the average fidelity ratings have been quite high, even when we are training really a novice to deliver the intervention. Most of the individuals that we've trained over the years have been individuals who have a background working and some experience working with families, and ideally Hispanic families. Some of the interventions sessions occur in Spanish because, again, a lot of the Hispanic parents that we work with are first generation. And sometimes they're in English and sometimes they're in Spanglish, right? So if there's a session that happens between the adolescent and the parent, the facilitator sort of adjusts to the particular needs of the family. So these are the average fidelity ratings that we observed when we trained the 40-plus school counselors who deliver the intervention, 2 per school, on a scale of 0 to 6, so about a 4. So not bad. To give you a sense, our master level clinicians achieve a 5, a little over a 5. So this is pretty good. In terms of our engagement rates and the number of sessions attended, almost 80% of the families engage in the intervention here. We're defining engagement as attendance in one of those 3 initial sessions, right? So there's a considerable amount of research that shows that if you can initially engage a family to attend one of the early sessions, the chances for continued attendance or retention in the intervention is significantly higher than if you don't initially engage early on. And so we've done a pretty good job at engaging families. And again, keep in mind that these were these school counselors who did not have as much experience as our master's level clinicians. So despite that, they were still able to engage a significant number of the families into treatment. And then the average number of sessions was 6.5. And this includes the 20% that did not attend any of the sessions. So on average, among those that we engage, attendance was actually closer to 8.5 sessions. We've had an impact on a number of different outcomes, including drug use and alcohol use in the study, as well as risky sex. I won't go through all of them. I'll just show you the one significant finding on drug use. Most of our findings are at least partially explained by improvements in some of the family functioning indicators that we assess and that really make up a significant part of the intervention. Some of the things that I described earlier, like parental monitoring of peers, family support for the adolescent, effective communication, etc. A number of years ago, we decided that, although we had some promising effects with the intervention in a number of different trials, the intervention really wasn't reaching a significant number of individuals, right? So it's sort of this issue of scaling up promising interventions, and we all talk about it, and you all do a phenomenal job at doing that, but not a lot of people sort of do a great job, right, about taking evidence-based interventions and integrating them into practice, whether practice be within schools, in community centers, in primary care, whatever the system is. And so one of the things that we realized that in order to maximize the chances of this happening is that we wanted to take this intervention and translate it into an online adaptation of it. So one, we thought that would help with the scaling up, and we also thought that could potentially help with that 22% that really doesn't engage, right? That they don't come to any of the sessions for a number of different reasons, including childcare needs, including the session not being, it's a closed group. So the sessions are at a given time on a given day of the week, and there are sort of real challenges and real world issues that these families face. And so attending a particular group session doesn't always make sense for all families. And so we, as I said, we then started thinking about what would this eHealth intervention look like. There are some very promising findings. Now I'm talking about 5, 6 years ago, where a number of different folks had published on the efficacy of health interventions, but also on the challenges with these health interventions. And one of the significant challenges of eHealth interventions was that it was often very difficult to also engage families into the sessions and really getting parents to log on to watch these sessions. And also for those that are logged on, as many, and I certainly put myself on this bucket, is that even when we do log on, whether it's to watch a YouTube video, whether it's to watch anything at all online, right, our attention span is limited, right? We probably can't stay on more than a few minutes, and it has to be pretty interactive and pretty engaging for us to remain engaged in what we're seeing. And so we spend actually over a year with some CDC funding on thinking about how would we develop this intervention. And so this particular study was actually led by one of my junior staff, where she led the adaptation of this intervention, and she's done a number of different trials now with this intervention. And so I'll quickly talk to you a little bit about it. The intervention, much like the original intervention, consists of 12 sessions, right? So here's sort of, if you go onto our website, this is what you see, and you see each one of the 12 sessions. We created this website as the portal by which participants access these sessions, but also as a way for us to track sort of what's happening on the back end, right? How many participants are logging on? How many participants are watching each of these sessions? How many times are they watching each of the sessions? Are they watching part of it and then next time they log on, are they starting again? Are they rewinding? So everything that you would want to capture sort of on the back end, we were capturing here as well. Here's sort of what the intervention consists of. There's the 8 parent or parent group sessions, which consist of 3 components, and I'll go through them briefly. And these are all sort of pre-recorded sessions or components. Again, I'll go through them in a second. On the right-hand side, there's those family sessions that I said happen in vivo, right, where the parents and their kids practice some of the skills learned in the group. And that happens live, face-to-face. Here, in this online adaptation, they also happen live, but now they happen through video conferencing software. Okay, so it no longer requires the family to come to our offices for this session to happen. So it happens all through video conferencing. So there's 4 of those. With respect to the 8, and actually I wish I would have included a video in retrospect, but I'm happy to email you all a video if you'd like to see. So the 8 e-parent group sessions now consist of 3 components. The first component, this is sort of our attempt to deal with the challenges of engaging the family early on, is that we developed 8 induction videos that introduces the 8 topics of the intervention. Effective communication, behavior management, parental monitoring of peers, adolescent substance abuse, adolescent risky sex, the school world, etc. So we created a telenovela series consisting of 8 episodes, each one very short, 6 to 7 minutes, that introduces each one of these topics by following one of these 3 families, okay, in the video. And I don't know, a lot of you here are very young, but for some of you who just are a little wiser, you may be familiar with the Que Pasa USA. Que Pasa USA was a show that was nationally syndicated. It followed the life of a family, of a Hispanic family, as they went through the acculturation process. And there were the grandparents who were very Hispanic and not well acculturated at all. And then there were the parents, and then there were the grandkids or the children, right? And so the script writer for that show, Luis Antero, was the one that actually wrote the scripts for this telenovela series. And so then we worked with our School of Communication to produce these 8 episodes for us. So again, very short, very engaging. For those of you that have seen Hispanic telenovelas, or any telenovela really, and you know how dramatic they are, and then every episode ends in a climax, and we'll see what happens, and people sort of turn in, even 6 months later, to sort of see what's going on. It's the same thing going on, right? This is how this is. This is how every episode ends. It ends in a very dramatic, climatic end that makes you want to come in. Actually, and I wish I would have done this, and I apologize. Whenever I've shown this video in a group like this, like 3 or 4 minutes, everybody's like, I get my first question typically at the end of this presentation, so what happened after that? Right? So it's really one of those. The second component of this was a real group of parents. So as you can see, we recruited 5 parents from the community. And this here is our facilitator, this woman here. This is sort of our Oprah Winfrey of our Department of Public Health Sciences. And she ran a real-life group with these 5 parents. Okay? Then we took those groups, those 8 group sessions, and we edited them down from the 90 to 120 minutes that they take to about 6 to 10 minutes each. And during that group, the parents can see these other parents processing some of the topics that were introduced in the telenovela. Okay? And at different points in time during this 8 to 10 minute segment, the talk show host would stop and say, so parents at home, what did you all think about this? Right? After that, this third component towards the very bottom, when the facilitator would say this, there would be an interactive exercise that would pop up in front of that participant's computer. And here's an example of one. It says, here's a list of, and you can't see it from here too well, but here's a list of potential goals that may be relevant for you and your family within the family world. Which one of these is most important to you, and drag some of these to the middle of this family circle. And so this was the part of this online intervention where we really sort of created or attempted to create that participatory process, right? Where the parents at home could feel, yes, we're watching this video, but we're also being engaged and being active. We used the responses that the parents put in the individual sessions that we then followed up via video Skype software. So it's sort of a little bit of personalized, it has a little bit of a personalized prevention element to it, right? And so again, it was a way to maximize our chances of engaging and retaining these families, because we really did make a very concerted effort. It wasn't perfect, and certainly there were challenges, but definitely as a way that, all right, we're soliciting input from you, and we're taking that input, and we are sort of customizing your subsequent family session with us. Okay? Yes?
Did you say you worked with Unidas for the video creation?
Say again?
Did you work with Unidas for the video creation?
No, we work with the UM School of Communication.
So, would you speak a little bit about I guess the pitch or the script that you all followed and the directing? How was that experience for you, and how much did that cost?
Oh, okay, yeah, good question. So it took over a year, and it took the time of two staff, not 100%, but a significant proportion of time. One of them was my junior person, who was sort of PI of the study, and then the other one was our master level clinician trainer who spent the past 15, 16 years with us. So the two of them were instrumental in getting our script writer, Luis Santero, and in meeting many, many times throughout particularly the first few months, sort of talking to him about the intervention itself, right? And essentially training him in the intervention so that he would be then ready to write sort of this telenovela series. And then after that, the video, working with the School of Communication, of course, they hired professional actors. We used sites out in the community where they filmed. They literally rented homes to do 3 or 4 days of filming. A lot of it happened in people's homes. Sometimes where we couldn't find a location, actually one of our homes was the location. And then even the editing of that second component, taking these 2-hour groups and editing them to be 8 to 10 minutes was a particular challenge without sort of losing the essence of the group. And again, we didn't want these sessions to be too long, because we don't want to put a parent through 2 hours of a session times 8. We're just not going to be able to keep these families engaged. So that editing process took months. And in terms of the amount, it took about $250,000 to do. So I won't go through all this. Like I said, my junior PI sort of led the development study. She then led an efficacy study of the intervention. Here you sort of see we recruited a couple hundred families and randomized them to one of 2 arms. The initial study, actually talking about finances, was initially supposed to test 3 arms. A control group, the face-to-face intervention, and the online intervention. But because the development of the intervention was much more expensive than we anticipated, we had to eliminate one of those arms with approval from the CDC, who funded this particular study. So we followed these families up through a year. We had some very similar effects actually in terms of magnitude, which, with what we had observed in some of our face-to-face study, and very similar mechanisms of action. So here you see some of the outcomes on substance use. We did some post hoc analyses to see where, what was driving a lot of those substance use, and it was mostly marijuana use and alcohol use, probably as you would expect, with a population that was fairly low risk, right? And they weren't using harder drugs, et cetera. And cigarette use, of course, over the years, according to the Monitoring the Future, has decreased over time, where that's typically not the preferred substance among adolescents anymore, unless you start including e-cigarette use and vaping. So interestingly enough, so very briefly, since I talked a little bit about engagement, I want to just sort of mention this and not go through it. So on average, participation rates in the intervention was higher than in our face-to-face studies, right? So you saw the other one about 6, I think it was 6.4, 6.5 on average. The number of sessions attended, in this case it's really watched, was almost 9, which was significantly higher than it was in our past face-to-face studies, both significantly higher in both attendance at the groups or the videos, and also in the family sessions, right? So both of those were significantly higher in the online. So probably maybe about 5 years ago, 6 years ago, when the Affordable Health Care Act sort of became the law of the land, we started thinking about, all right, so how do we gain, now that we have this online adaptation that seems to be fairly promising, how can we take this and integrate it within healthcare systems? And most of our work, as I mentioned earlier, had been done with schools. And we started saying, all right, so can we do a small feasibility and acceptability study showing the promise of this online intervention in different primary care settings? And so we embarked in this approach. We worked with 4 clinics in Miami-Dade County. And actually, somehow, all of them were associated with or affiliated with the University of Miami. This was with our pediatrics department. We have a mobile clinic. And so you saw some of the sites there. And so we did a very, very small, I think it was 27 or 28 participants that we enrolled into one of the 2 arms. And we did not collect any outcome data here. Really, we were just looking at really feasibility. Is it possible? Do people show up? Can we recruit from primary care settings? What do the clinicians think? And so we gathered some qualitative and some quantitative data. We were incredibly successful at engaging families that were being recruited from the clinic to participate in the study and in the intervention. As I said, we collected some data, some qualitative data on parents, also on some of the clinical staff, and parents consistently, and we're not the only ones that have found this, that basically parents say, this setting meaning primary care, is a much better setting to recruit from, at least for us, than school settings. And parents mostly found primary care to be less stigmatizing than schools, right? So parents sort of associated the school system, and particularly getting a call from their school social worker or their school counselor with, what is my adolescent doing? Or do you think that I need some type of behavioral intervention? So it was a little stigmatizing where it wasn't within this particular setting of primary care. Here's a quote. In the school system, you don't meet anyone unless you have a huge problem. They don't call you saying your kid is on an honor roll. They call you only if there's a problem with the child. Should be different. As I mentioned, we collected some data on our clinicians. I won't go through it. But sort of here's a quote from one of the clinicians saying, yeah, this sort of works, right? There's some promise here. And so because of this, we completed, and here's sort of my last slide, and then I'll leave the last 15 minutes for discussion or Q&A if there are any questions. We decided that we wanted to embark in a full effectiveness study in primary care. And so currently that's ongoing. We have finished recruitment now of 456 Hispanic youth and their families through primary care. We worked with 14 different sites across the county, some of them affiliated with our university, but other sites that were not. federally qualified health centers, smaller practices out in the community, and we were very successful in terms of recruiting the number of families that we set in the time frame that we expected. Actually, we were about 2.5 months late, but in large part that was because of the hurricane a number of years ago. And so the engagement rates have been just as high for this one. So of the 226 or 225 or 226 participants randomized to the experimental intervention, the average attendance, again, these are sessions watched or actually participated in, has been 80%, which is pretty good, for these families. So that's one thing that we currently have ongoing. We currently have a research program as well in obesity prevention. So there's been we've had a number of different, either myself or some of my postdocs have had obesity prevention studied by the NIH. All of them sort of consistent with the work on the parent being the change agent and on family-based interventions. In some cases, they've been face-to-face interventions. In the current study right now, it's developing actually an online intervention to promote physical activity among Hispanic families. And then a second study where we're working with cancer survivors and also developing a multi-generational intervention to promote physical activity and quality diet among cancer survivors. We've also recently, over the past 6-7 months, have begun working with sexual minorities. So these were specifically with Hispanic adolescents who have recently disclosed their sexual orientation status to their parents. And so we've developed actually an intervention called Familias con Orgullo that we are currently testing for feasibility and acceptability, and just about done collecting those data and setting our foundation for hopefully what's going to be a June NIH submission for that. As I mentioned, we have our, one of the things that we're very interested in is we're very interested in taking these, this intervention and some of the other ones that we're currently working on and really sort of disseminating them, right? So taking them out of the publications and outside of the research lab, nationally into other places. And so we've been doing that with the intervention. So currently we're working in a number of different sites and it's being implemented in Boston and Rhode Island and in Pennsylvania and in a couple of other places. We also have some work happening internationally in Ecuador and in Chile. And the most exciting one for us is actually in Chile, because we've been working there now for about 8, maybe 9 years now. We've been working with a foundation in Chile that has been very interested in the intervention and adapting the intervention for their cultural context. And they have done so. And this particular foundation is very well connected to the federal government. And so now, actually we're finalizing, but the Chilean federal government is allocating funding through their federal budget to implement the intervention in 10 of the 350 plus regions in Chile, with plans to grow to all 350 regions over the next 5 to 6 years. So that to us is pretty exciting. And finally, we're in the very early stages. I shouldn't say that early because we just applied for funding, submitted our grant in February, where we're hoping to sort of that figure that I had from pre-intervention to efficacy to effectiveness to implementation studies. So we're actually just submitted our next study where we're looking at effectiveness and implementation of the intervention in primary care. And this is sort of just a very quick snapshot of what the design for this study looks like, where we are going to be, so on the y-axis there, you see the number of clinics. So they are a total of 18 clinics that will be participating in the study, and we'll be randomizing clinics essentially to time of when they are going to move from being a control clinic to being an experimental clinic, much like a step wedge design. For those of you that are familiar with step wedge designs or rollouts. And what makes this really sort of an effectiveness implementation is that in addition to collecting some of the outcome data that you would typically do for an effectiveness study, things like looking at drug use outcomes, or in this case actually they're mental health outcomes, we're looking at depression, anxiety, and suicide ideation and behavior. One of the things that we're very interested in also in looking at implementation related outcomes. And so one of the things that we're very interested in is in the sustainment period. So essentially, Okay, there we go. So in the sustainment period, so after the research team completely pulls out, where there is no funding left for this intervention, for the implementation of how many of these clinics and how many patients within each of these clinics are going to be able to receive the intervention. So our implementation outcome is how many individuals can we get these clinics to provide the intervention to after all funding has ended. And so we just submitted that. Hopefully we'll hear in back a few months. And then finally, I'd just like to end with 2 slides, thanking certainly NIH and mostly NIDA, who's funded a lot of this work, and of course our community partners, the clinics, the schools, all of our collaborators internationally, and then just sort of the research team. And I'm very, 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 very lucky that I've had like the same research team since I started 15 years ago. And, I couldn't do this without them, and they're all still there. And everybody tells us we're, again, a lot of them are psychologists and social workers. So we're a little enmeshed, right? Because we really do everything together. We, as you can see, we have a lot of fun. And whenever we travel on business, all of our significant others then join us, and then we all take vacation after that. So it is sort of a little enmeshed, a little borderline-ish perhaps. But anyway, so with that said, thank you all. It's been a pleasure. So happy to take some questions. Yes? And then back there.
Why are you doing this and why do you get it?
Excuse me. So for me, when I first started my doctoral program, I first learned about a lot of the treatment work that Jose Shaposnik, who's my mentor, was doing, and I wanted to sort of do something on the prevention end, on the prevention side of things, and I wanted to be able to give back, to my community. I was sort of raised here, and I'm a prodigy, if you will, of the Miami-Dade County public school system. And so it has been really, really rewarding actually to work with the exact same middle school and high school that I attended for many years. And and certainly also, in addition to a great way of contributing, Hispanics in general are at increased risk of some of these outcomes that we've been looking at, things like drug use and alcohol use and unprotected sexual behaviors relative to other groups. You're welcome. Yes, I think there was a question back there, and then we'll go back.
Yeah, just a clarification
Sure.
question on the recruitment from the primary care settings. So would that be done with the idea that you recruit from primary care, but then they would attend sessions in like a sort of standard outpatient clinic?
Okay, yeah. So we recruited from primary care, and what happened, and it varied a little bit from clinic to clinic, depending on the clinic flow and depending on what the physician or the office manager was comfortable with. Most of the time what happened was that the parents would get the first session in the waiting room while they waited to be seen, so the session was a little less than 15 minutes. And so they would get that first session, and then after that, everything else happened elsewhere. So it happened at their home most of the time. Yeah, question back there, and then here.
You may have said this, but the intervention itself, is it targeted towards a culture of distress, or is it more like helping parents around teenage behaviors? And then the second part of that is I'm wondering, the first answer may inform the second, but I think you mentioned that you had rolled it out in Pennsylvania and Boston. I'm wondering if you were targeting a culture of stress among Hispanic families, if you adapted it at all.
Good sets of questions. So the answer is that the focus wasn't on acculturative stress. It was really more on the kids' behavior and the family processes. Having said that, a lot of times what we see, particularly with sort of our immigrant families, is that we realize that a lot of those maladaptive family interactions was rooted by sort of this acculturation gap, where the parents did not want their, I'm almost describing my mom here, but they didn't, parents did not want their child to sleep at so-and-so's house. It was okay for anybody to come visit us, but God forbid I wanted to sleep at somebody's house. And, the parents were seeing that as very deviant behavior by their adolescent. where in fact, clearly wasn't deviant. It was just sort of being more acculturated. And so what we did, it wasn't that we were sort of targeting acculturated stress per se, but we tried to normalize those behaviors within the family and telling mom or dad, most of the time it was mom, this is sort of normative within the US culture.
Yeah.
And some of the other places that we're working in, the intervention hasn't really been when we did it internationally, there were some more adaptations that were made. But really, in other parts of the US where we're doing this, there really have been no adaptations. In large part because a lot of the community centers that we're working with, they have a significant Hispanic immigrant population.
Okay.
Thank you. I think there was yeah.
I get the intervention is targeted toward the parents primarily. And the graphic you had, the paths of the substance use outcomes, I'm assuming those are the kids.
Yes, those are the kids' behaviors.
So I'm curious at how folks are selected to get the intervention. Is it parents going to the doctor saying their kids are already using, or that they think they might be at risk?
Well, yeah, good question. Most of the time, because we've been working with a universal sample, including in this primary care study, it's a convenient sample, and that obviously it's those that want to participate. But we approach everyone, right? So typically the way that it worked, at least in this primary care study, is that whenever there was a family that met the study's eligibility criteria, essentially they had to be between the ages, they had to be Hispanic, they had to be between the ages of 12 to 16. If we knew, based on what the physicians or the office staff of the physician was telling us, that there was an adolescent that particular day that had an appointment that met this inclusion-exclusion criteria, then we would show up to the clinic, right? And essentially, because we weren't provided the detailed information as to who this was, for purposes of HIPAA, anybody that walked into that clinic during that time frame we were there, we would approach, essentially to explain the study and to find out if they would be willing to participate.
So a follow-up to that, one of the struggles in working with the adolescent and substance using samples is always obviously making sure that they feel comfortable sharing their substance use information with us. So I'm just curious if there was any sort of toxicology testing to track the kids. And if they're not in a situation where the kid's like, oh, screw this, I'm a pot smoker, now my parents are on to me now. I got Dr. Prado telling me to ask me about how much I'm smoking all the time. It's like, all right, nothing, man. I'm good.
Yeah, so the answer is yes. So we do collect those data. Traditionally in the past, everything had been self-report. Now for this particular primary care study, we are collecting some toxicology, we're collecting urine. So and so, I think we can rule out the fact that, certainly at least for the follow, even some of the follow-up assessments that people aren't coming in to assessment because it's time, for urine or, STI test or whatever it may be. So I think, and it's hard to really quantify that, I think, but it wouldn't surprise me if some of that is going on.
So I'm assuming you also have other outcomes, besides the substance use outcomes. Just
We do.
are the families talking more? Is there
We
less
do,
conflict?
no doubt.
All that good stuff.
Absolutely, yeah. So a lot of, if you look at a lot of our boundaries, certainly some of it is around substance use and risky behavior. Some of it is around, which I didn't present here, but I have one colleague who's done, Tatiana Perina, who's done a lot of work on depression and suicide ideation with the intervention, looking at crossover effects of the intervention, because it's some of the same mechanisms of action, right, that are related to depression versus substance use versus other outcomes. And so, in addition to all of those behavioral and mental health outcomes, we have a significant assessment on some of those family indicators, as you mentioned, yeah. So a lot of family communication, support, positive parenting, parental involvement, that sort of stuff. Yes?
Can you speak a little bit about what you envision for long-term scalability and sustainability? So do you envision this as being a subscription buy-in perhaps for clinics or something? For other families?
Exactly.
What would you like to do? What do you think about?
Yeah, so what we would love, and what we would love is, to be able to contribute, to the literature so that the U.S. Preventive Task Force can say, this intervention and other interventions like it, do have the evidence in primary care for us to be able to sort of implement this in primary care, get it reimbursed for, and so that's sort of like, the dream. Although, in some ways we're sort of, to be honest with you, with this experience in Chile, where there's this federal, we've done a lot of studies, we've enrolled, a couple thousand participants. And just over the past 2 years in Chile, the intervention has reached thousands of families. And now, over this coming year, with it essentially being open to all kids who want to participate in these 10 350 regions, 356, I think it's regions in Chile, we're going to, just in this year, reach 2,500 families. So that in itself for us is already huge. We think of these studies and there are 200, 400, 500 families, and these studies take 5 years. So to be able to see this all of a sudden, in 1 year reach 2,500, I think we're sort of living the dream in some ways.
Great.
Thank you. Yes.
Can you speak a little bit more about how the treatment is adapted to youth who disclose their sexual identity?
For youth identity, yeah.
And how are they referred?
Yeah. So so for that one, some of the central tenets we've taken from the intervention, the focus on the family. But to be very candid, if you sort of put the two interventions side by side, they are very different, right? I mean, this population is very different. I think there's there's issues around acceptance, right, that are very big and significant. The family dynamics are just sort of very interesting. Parents are not exactly where they want to be, even when they are supportive. It's not just the type of support that the adolescent is sort of expecting.
Yeah.
We've also felt the need, and this was in large part because of some of the qualitative data that we collected, that in this particular intervention, all of the sessions are parent-centered. So here, they're not. So we do have actually 4 intervention sessions that are really for the youth themselves, right? That are not parent-centered. It's sort of still around family dynamics and how to help your parent, cope and accept, and what are things that you can do, and certainly working within the family, but it's sort of not parents. I mean, it's a very, very different intervention. It really is. And it's, we've been pretty excited about it because, and I knew from the first session that this was going to be we've run 2 groups. And so in the first group, we had mostly moms, but occasionally we get a couple dads. And so this was the dad of a young woman who self-identified as gay. This was a 13-year-old girl. And one of the first activities that we do in the sessions is we pair up the parents and have the parents introduce themselves. This one mom was introducing the dad, and then after the dad was introduced, the dad said, "Well, yeah, I'm here for the same problem that we all have." And then one of the moms said, "Well, I don't really see it as a problem. This is how I see it." And it was just like very, very powerful and pretty exciting.
How are they referred to the program?
So so this woman that you saw on video here, we tell her that she can run from here at Miami-Dade. So she's connected with just about every place you can think of. She's out in the community. She goes to the Pride events. She goes to the Yes Institute. We collaborate with the public schools and collaborate with their GSAs. So we work with their gay straight alliances. So you name it. It's very difficult to recruit this population. And for the first group had 12 participants. She recruited everybody in the 4 or 5 days. I mean, it's quick.
Thank you very much
Thank
for
you.
coming. Thank you, William.
Thank you all.
We're going to get lunch. We have lunch next door, 117.